All right. Good afternoon, everyone. I'm Dr. Bruce Strumminger, and I'm an associate professor at the University of New Mexico and with Project ECHO at the University of New Mexico. I'm one of the co-chairs of this session. And I just want to welcome you all on behalf of my co-chair, Lisa Chen, who is the director of the Curry Center at UCSF. And I want to thank my presenters who you're going to be hearing over the next hour and a half. We have a really fabulous panel of program directors who are going to highlight the wide variety of ECHO variable variations that they have been implementing in their local contexts. I also want to thank all the people who are showing up today for expressing your interest by being here. So we've each got about 10 minutes, so we're going to rapidly, hey Jane, I like your Kenyan cloth there. We're gonna highlight 6 different programs, and hopefully we're gonna have about 20 minutes at the end for questions and discussion. So first, I just want to say I have no financial conflicts of interest or others. And listening to some of the talks about ending TB, as we think about the work we have ahead of us to end TB, it's going to require all hands on deck, and it's going to require everyone with expertise of all kinds, whether they're national experts or frontline nurse managers, ASHA workers who are doing DOT. Everyone has expertise of different kinds that they bring to the response to TB globally. And in bringing all the knowledge and experience together of the people working on fighting TB, we're going to need a variety of platforms to make the knowledge and experience they've got easily shared so that best practices rapidly get shared across country programs or across regions, continents, et cetera. And that's the piece of the puzzle that Project ECHO tries to address. It's an education and workforce development initiative that builds virtual communities of practice. And our mission is to democratize medical knowledge and help get best practice care to underserved people all over the world, and hopefully to help the lives of 1 billion people or more by 2025. And TB is a major part of how we're trying to do that. So this slide in some ways is the most important. It summarizes the methodology. There are 4 key principles. One is creating these communities of practice by using video conference technology, which has become extremely inexpensive and easy to use. People can use their smartphone and over a cell phone network connect to a video conference, and this just makes bridging geography much easier. So that's the platform, and then to me the most important part is case-based learning. So using real cases, presenting real patients that need assistance, and then discussing those in the same way that doctors and nurses learn to take care of patients, or discussing programmatic issues are often cases presented. Sharing best practices, whether those are national or global guidelines, evidence-based practices coming out of the literature. This is a platform that can help share those best practices in a very rapid, real-time manner. And also monitoring and evaluating outcomes. So whether it's very simple feedback that we often encourage people to get for continuing professional development credits, or doing more elaborate evaluations that might be as complex as a randomized controlled trial, trying to get evidence about the programs being implemented to improve them and help focus them. So just quickly to differentiate ECHO from telemedicine, ECHO is a telementoring telehealth program. The goal is to train providers and healthcare workers. We never see patients on the network. Those providers are educated to then provide the care to their patients. It's an all teach, all learn model. So to me, I think this is the most revolutionary introduction, is this idea that everyone is in a non-hierarchical learning environment, and everyone who participates has something to teach the others in the groups. So encouraging a very dynamic interaction between national or international experts as well as frontline health workers. We often hear it's the peer-to-peer learning that they find most valuable from these sessions. I think one of the great opportunities of a platform like this is building bridges across the different pieces of a healthcare system, which are often fragmented, so between academic medical centers, ministries of health, private sector, public sector. There are a lot of pieces to the healthcare system that are required to help patients with TB complete their treatment. And being able to easily bring them all together in a virtual network makes this much easier to promote that kind of collaboration. Force multiplication, this idea of interprofessional learning and teaching, of bringing together doctors, nurses, laboratorians, epidemiologists, community health workers, both at the hub or expert level, and we really encourage the teams at the local level to do the same thing. This is just to highlight, in 2011, there was a New England Journal article published about the hepatitis C program. ECHO started at the University of New Mexico in 2004 in response to our hepatitis C epidemic in New Mexico. We had 1 or 2 doctors trying to treat 30 to 40,000 patients. That wasn't really working out so well because he was only able to treat a couple hundred a year. And so Dr. Sanjeev Arora, who started this, had this idea, if he could mentor many local clinicians and teach them the skills to treat hepatitis C locally, we could treat many more patients. And now 80% of patients in New Mexico are treated locally by their primary care clinicians for Hep C under guidance through this ECHO program. So this is just to emphasize that working through our partners, this model is one, we're a sharing community and we provide training that we do not charge for because we receive support from the GE Foundation. So every month in New Mexico, people come and receive 3 days of training in this model, and then they go back to their home institutions or their local context and implement their programs. In the United States, over 35 states are implementing programs related to more than 50 different disease areas or healthcare process areas. And globally, there are now over 25 countries implementing a variety of ECHO programs, and at least another 10 or 12 with programs in the pipeline. TB. 2 years ago in South Africa, Lisa and I helped lead a symposium at this meeting, and at that time, Vietnam had just launched the first ECHO program in the world, and New Mexico had launched the second ECHO program in the world. Now, 2 years later, there are over 12 ECHO programs there are almost 15 programs in 12 countries, either implementing or in development. Just to give a shout out to Dr. Nguyen and the program in Vietnam, they launched the first program in February of 2015, linking 54 TB MDR teams across the country. And then New Mexico, you're going to hear more from Diana Fortune, who's the program manager. This is a nurse case management focused ECHO. One of the wonderful things you're going to hear through our presentations is some of these ECHO programs are implemented in high burden settings, like in Delhi, where they treat 60,000 TB patients a year. In New Mexico, we treat 50 patients a year. But that poses other challenges of keeping knowledge and expertise alive when there's so few patients. So that there's different needs, and it's nurses who are doing the care in this case. This is just to highlight that we used a standardized template when patients are presented, and in this case, it's our New Mexico TB record. And to give a shout out to some of our colleagues at the University of Washington who couldn't be here today. They started the first program that also addressed TB infection, and they cover 3 or 4 different states in the northwest of the United States, and it's a collaboration between the University of Washington and Department of Health. Diane is also going to talk about this program. It's the Navajo Nation TB ECHO, which focuses on our indigenous population of Navajo Native Americans, and it brings together tribal healthcare workers with state departments of health in Arizona and New Mexico, as well as the CDC, our national public health agency. You're going to hear from Dr. Kameni about her MDR program, which was the first in Africa. and from Dr. Serene about the Delhi National Institute of TB and Respiratory Disease Program. So these are just giving you a few highlights. And just as I wrap up, I want to also mention that on a quarterly basis, we actually bring the program directors of all these programs that are implementing or in development together over a 1-hour session to talk about the challenges they're having, the successes they're having, and so we can share resources, including PowerPoint presentations, case templates, etc. So my last 2 slides, which actually go over the benefits of applying ECHO to address TB, I'm not going to go over these in detail because I'm out of time, but I know that all these benefits are going to be highlighted by my colleagues who are going to present about their individual programs. So with that, I want to actually invite our next speaker, which is Dr. Maureen Kamene, who's actually, as of last week, the director of the National TB Program in Kenya. And so we can also give her some applause for becoming the director of the national program. So Maureen, come on up. And if our IT team could reset the timer and pull up our next. Great.
Okay, so I'm Kamene. I'll be giving the Kenyan experience for TB ECHO. The ones who were here last year got to hear about how we initiated ECHO, but now it's just thereafter what has happened. So I have no conflict of interest to disclose. So just a bit of the background of TB ECHO in Kenya. So basically the goal for TB ECHO was to increase the access to specialist care countrywide. And our target was mainly at the beginning drug-resistant TB, where we felt we had least expertise. So we wanted to improve patient care, enhance access to technical expertise, improve surveillance for drug-resistant TB, and also improve diagnosis and management. So we started to discuss the areas to focus on. First was drug resistance, as I've mentioned. And then during that time, we were also introducing pediatric TB, the new drug. So we also decided to focus on pediatric TB and also started to discuss the rolling out of new policies. So we're introducing pediatric formulation. We're thinking about the short-term regimen, among others. And then also there was the new drugs. We had bedaquiline coming into the market, and we also wanted to be able to monitor that and also support the Somalia program in drug-resistant TB, and eventually decentralize, discuss and demonstrate most of the skills that people need, for example, in PAL, among others. So objective 1 was basically to provide timely clinical review and nursing care. We also wanted to provide continued professional development and clinical care through case-based discussions. And then finally, we also wanted to strengthen knowledge and skills for TB patients. So what were our traditional ways of passing information previously and also discussing patients? One of the ways was, of course, the usual training where we go for 5 days. Now, if you know the kind of people you train, the average person, healthcare worker who needs training is 42. That was our average. You know, at this age, we have so many things on our minds. So you go for 5 days training, but you only retain 20% of what has been taught. So when you went back, you realized you did not have as much information as you thought you had. And when a patient was presented to you, you start making phone calls. So the other thing that people did was to make phone calls frequently, and I was the only person at the time who they used to call for guidance on drug-resistant TB. So we also had clinical meetings. So every patient had to be reviewed on a monthly basis in the clinical teams. And if these people didn't have knowledge, they would also still call back. And there was technical expertise, technical assistance that is done on a quarterly basis without adequate time, and maybe the person providing does not have as much expertise. And then also site supervision and people reading guidelines. We all know reading guidelines at the workplace is a challenge. So those are some of the challenges that we are facing. So we came for training last year, I think February, on ECHO. And the concept basically is we have a hub at the National TB Program. And then we decided, okay, so what equipment do we need? At the time, the only available thing we had was either a laptop, or you have a tablet, or you have a phone, or something like that. So we decided to use what was available at the time to start ECHO. Well, did we have internet? Yes, we had internet. So the kind of internet we had is just use of 3G network with our phones, or either you use a modem or something like that. So we didn't have all that, and we didn't have resources to set up. Did we have cases to discuss? Yes, we had a number of cases, so we decided to pull out cases for studies. And we identified didactic presenters for the case. And then we also developed a curriculum that we would be using at the time. And then the other thing, of course, you needed a camera, because majority of us had either a phone or a tablet or a laptop. Automatically, there was a camera. So how do we go about it? We first of all start to advocate for it, for ECHO, slowly by slowly. And then we identified the clinicians who needed to be part of our team. Mainly there were TB coordinators, and then where there were clinicians available, we used them. We also looked at our training manuals, and we identified the cases to be studied. How do we do it on a weekly basis? We do an invitation on a weekly basis. And then we have provided one meeting ID so that people don't keep asking, what is the meeting ID for next week? When is the meeting? So we use one ID, and everybody now has kind of known what ID we use. And we send reminders even the day before for the ECHO sessions. So what is the aim of ECHO? Basically, we want to make sure that our patient, in Kenya we call them Wanjiko, that is a common citizen, has the best quality of care. We answer frequently asked questions by the patients and by the healthcare worker. We also provide a place for them to access care. We tell them where is it you're going to access care, and we also have discussions on the side effects. One thing I want to mention is at the end of every session, we have 5 minutes where we discuss programmatic issues. So the status we are in now is that we have many spokes, but the ones that are in clinical settings are 10 that are active, but the other spokes are mainly TB coordinators and sub-county TB coordinators. We have one national hub. We meet on a weekly basis and discuss different cases. And then our sessions have been open most of the time. And what areas have we been able to cover? We have had case studies and policy updates on various areas like the drug-resistant TB. Now we are introducing the short-term regimen. We have already had sessions on that and many others. We have done sensitizations on the various areas as shown. And we have also been able to disseminate policies and survey findings using ECHO. So that shows the cases that we have been able to discuss. MDR-TB, we have discussed 7. Short-term regimen, we have had 2 cases. And in between, you are able to see the participation broken by age and sex. And you can see we have done well with over 267 people in total attending MDR-TB. One which was very well attended was leprosy. In leprosy, we had an ECHO session for leprosy, and what informed this was the absence of training and absence of funding. So we decided to use ECHO to train. And we had case studies. And this one was the most attended session of all. There is one time we had 156 people calling in. You can imagine we couldn't, that is not allowed in ECHO, but you can imagine they all just listened in. Only a few people were able to ask questions. And that led to a lot of discussion actually in our office. Should we have ECHO only for 30 participants, as is the guideline from the training? And we agreed they can listen in, but we know particular people are the active ones. And so we spend a lot of time on the chat, because that's where they are able to communicate most of the things. So those are some of the ECHO sessions in different places, and our ECHO presentation tool that is shown at the bottom. So what have been our benefits for ECHO? This one I am running out of time, so I'll just say all of it in one short sentence. So we are able to discuss our policy guidelines. We're also able to answer frequently asked questions, discuss ADRs, case studies, discuss our programmatic issues like commodities. Now, the interesting thing about ECHO is when we started ECHO, we just wanted to discuss cases. But after that, people wanted a forum to continue asking questions. So the first thing we did was have WhatsApp group. The WhatsApp group was a reminder, but suddenly it became a place for case discussions. So the numbers were not adequate, 250. We moved into Telegram. So with Telegram, cases continue discussions. People continue the discussions of what has happened in ECHO. And then what has happened in the end, we have been able to pick gaps in our guidelines. We have been able to pick best practices. We have also been able to understand, there's a way you add something in a document. It doesn't make sense. We have also been able to clarify those gaps. Yeah, so in the end, we feel that the patient is now getting better care. So case finding has been increasing since. We launched in August 1st, and you can see there's been an increase in case finding. I don't think that's the only thing that has made the case finding go up, but we see maybe there could be a relationship. Gene expert utilization has also been increasing from 1st of August last year. We have also noted that. And then just now to finalize the next steps, we are planning to have a technical working group. In Kenya now we have many echo sessions that are going on. We have HIV program doing echo. We have many other people, and we want to utilize the same equipment that they use, the same expertise, so that we can have one big echo. Someone proposed the name, an echo university, so we could try using that. We also want to able to set up CPD points. We had started, but funding issues came in between, so we have not been able to set up the CPD points. And we want to create 25 new echo hubs, which will be addressing now the counties. We have now some funding from Global Fund. Hopefully next year we'll be able to do that. We want to assess what has been the impact of echo on quality of care. We'll be able to get our first outcomes from the time we started at the end of this year. We also want to expand echo to other conditions. We have already done for leprosy, as I mentioned. Now we want to go into lung health generally, which is part of the NTP mandate. So we look at asthma and we look at COPD. My time is out, but I think I can say why. I can say, okay, thank you. We can just talk about the opportunities that ECHO has presented. One, we are able to collaborate and share existing infrastructure and expertise with other partners. We are able to use the affordable and readily available 4G network to improve our echo sessions. We are also able to recognize, we have also been recognized now as a means of training and capacity building by the Ministry of Health. And now we are planning to integrate training with institutions and also strengthen our partnerships through the use of ECHO. Thank you very much. This is just a pictorial of just the people who are involved and our bigger picture. Thank you.
Thank you, committee. It's my great pleasure to bring up our next guest speaker. The wonderful thing is that we're graced with the latest winner of the Carol Steve Lowe Award announced this morning. And so without further ado, please, Dr. Rohit Sareen, who is now the director of the National Institute of TB and Respiratory Disease in India. So congratulations, and please come on up.
Well, friends, very good afternoon. And yes, we are here to discuss the future. The National Institute of TB and Respiratory Diseases is fortunate that we came across a person called Bruce and his team, and we also came across an individual by the name of Dr. Anand. And about less than a year back, we started on with this endeavor. You all know where we stand in terms of TB. We have the dubious distinction of heading the list, whether it is drug-sensitive TB, whether it is drug-resistant TB, whether it is TB, HIV, yes. Huge numbers. And to look after these huge numbers, we definitely had to have a different thinking process. It became all the more important when we worked towards the end TB strategy. How can we really end TB with this huge burden in the country? And then, you see, we came across this new platform, the ECHO platform. And we decided that yes, for a particular group of patients, though of course this platform can be used for anything, any teaching, any learning, as my colleague from Kenya has already elucidated in her last slide. But we decided to start with, let's try to see what we can do with the most difficult to treat MDR-TB patients. We realized that our centers of excellence were far across the country. You could not have that expertise down in the periphery where the patient really is. And that is the time when we realized that yes, we need to connect with the periphery. We need to connect with the bottom. And that is what this particular program is all about. We had to take care of the catastrophic costs which we talk of the patients, the traveling costs, the wage loss. And this is an excellent way to, look and address this issue. We understand drug-resistant TB is not only a huge burden in terms of the mortality and economic loss, it has a long duration of treatment, a requirement for the patient to be with the system for more than 24 months, and with drugs which are really toxic, ADRs which really need very close monitoring. So under this scenario, we decided to use this specific platform. The basic objective was to disseminate the expert TB knowledge to the periphery and covering all the aspects of TB management, and to reach the maximum number of experts, maximum number of people in the periphery in the shortest possible time. The target was not only doctors, it would be all healthcare providers, whether it would be nurses, whether it would be the peripheral dot provider, whether it would be laboratory technicians, each one of them would be given the benefit of this particular program. So the model which was developed was that at the National Institute, we had the central hub, and then we held these weekly tele-echo clinics. In Delhi, we have a system wherein there are a number of districts, chest clinics, and which manage the patients in the periphery. So about 30 to 35 district TB officers. The different states joined us subsequently, and the state TB officers became part of this clinic. And then the DR drug-resistant TB centers, which were centers of excellence for managing, it all started with this group. And the tele-echo clinic is not a very long duration teaching session. It's short, 1 hour, focused. And how we go about it? We go into didactic lectures, into the latest in what is happening, whether it is diagnostics, whether it is treatment, whether it is using information technology, and also the guidelines of the Government of India. And in addition, we also then discussed actual patients, the cases, difficult cases, and it was a learning and sharing experience. You see, each of the DTOs, as we mentioned here, each of the STOs would bring out their specific problems and their specific cases to look into how to handle this, to share how they handled that, and therefore, the learning is much wider than what we can get from a didactic lecture. It's a positive platform, excellent presentations by best experts in the country, case presentations I've already talked, and yes, difficult to address ADRs which may happen. Participants go home really with a much more knowledge and patient benefit in mind. You see, this is essentially what the participants look like and what the hub has to offer. But in addition to the chest specialists and the coordinator and the microbiologist, we also have, other specializations joining us. We have the ENT specialists. We all understand injectables lead to a lot of auditory issues. We have the psychiatrist on board. Yes, drugs like cycloserine and even the quinolones have a lot of ADRs as far as the brain is concerned. So you need support from all others. I mean, this is just citing an example. You could have on board really as many specialists as you want, depending upon what specific drug reaction or adverse drug reaction you are talking of. And you can see that in the spokes, you have all types of health providers. You will even have paramedical officers, NGOs, and you name it, it's there. And we as the hub would give the not only how we practice, but then we also, our faculty also learns. This is, one of the sessions which is happening, and you see our team there. Some of the team participants are here. My colleague, Dr. Rupak Singla, is also here. You can see him sitting there in one of the programs. And then you see the different spokes who have joined us in this specific echo clinic. For the past 11 months, we have about 36 clinics, and on an average 35 spokes, and each spoke has a number of participants there. Total of about close to 150 participants are there. And it's not only limited to, states within India. You find international participants are also joining us. So that's another opportunity which we see. It's again learning from each other. The feedback is also very encouraging. You can more than 90% on all counts, whether it is the type of presentation, whether the relevance of the clinic, whether we talk of newer information, or whether we talked of a specific case. The feedback is really, really very positive. And if we see, some of our doctors from different clinics, they have given us written feedbacks on the specifics of the clinics. These are different spokes which have the district TB officers, giving their comments on and writing back to us. And I'm sure that any such feedback would not only improve the quality that we are doing, but would also encourage us to go ahead further. And now we have expanded within the state from 1 to 4 hubs, and we have in the process of expanding within the country to other states. In fact, all aspects of TB care are encompassed in this particular clinic. The journey so far, it has been a learning experience, capacity building, not only of the participants, but of the faculty of the institute. And this has helped us in the networking with other organizations and institutions in the country. But there are challenges. I would say even today, when I reflect back, it was very difficult to get all stakeholders on board. To maintain the high standard of the clinic is another challenge. When we start with initial months, you would have excellent faculty giving the presentation. But to ensure that this happens in the rest of the clinics is really something which is very important and challenging. And the same goes for the participants. It is, to start with, we started only with doctors. Then we moved on that, yes, we cannot limit it just to doctors. The nurses, sessions for the DOT providers, specific sessions, specific learning things were got on through this particular clinics. These are the different types of cases that we talked of. I'm sure most of you would have had similar challenges and cases within your own institutions. And these are just telling us something about the feedbacks sessions and the performance which we circulated in terms of the relevance of the clinic, the type of patients, the type of didactics, and so on. And on all counts, you find that, yes, the NITRD ECO program has scored. The stakeholders, yes, we are supported by CDC, we are supported by the National Institute for Research in Tuberculosis, and of course, that's Project ECHO and the NITRD. Friends, there is no conflict of interest. Whatever I present here is really presented as part of the ECHO TB program. Thank you so much for your patient hearing.
Thank you, Dr. Serene. That was a great presentation. So now it's my pleasure to actually welcome my colleague from New Mexico, Diana Fortune, who is the TB Program Manager for the Department of Health of the state of New Mexico. And Diana also is going to become the president of the National TB Controllers Association next year. So Diana's going to talk about the New Mexico Department of Health TB ECHO program, which was the first program in the United States.
Yes.
Thanks, Diana.
Okay, thank you, and nice to see everybody today. And I would like to say also, besides being the TB program manager, I am a nurse, so I like to think that nurses can bring a special perspective to the TB program as the manager also. I have no conflicts to disclose. And I thought just to give everybody a little background, New Mexico is where the great big red arrow is pointing. We are a very big state with very few people. There's only about 2 million people in our entire state, so everybody's spread out over a very large geographic area. We are very low incidence. I'm sure some of you guys in here, when I say we only have 39 cases of active TB last year, would be amazed at a state that has so few cases. And so we're really kind of on the edge of we could start looking at maybe TB elimination and start really working on treating people with just TB infection. However, we do still have 39 people that have TB every year that are very complicated, that we want to make sure that everybody gets the best possible care. So our focus of the TB Echo Clinic is a little bit different than some of the other ones. I wanted to focus specifically on the nurses and helping the nurses to develop nurse case management skills, and not only to have the skills, but to feel confident in their skills too. A lot of people are isolated and they don't have any other nursing folks around to kind of talk things over with. They may know the answer, but they don't feel confident in knowing their answer. So initially when we started, we presented every single active case that we had going on at that time in the state of New Mexico, which was usually about 20 to 21 patients, and that took about 3 hours. We did that for a couple of years, but it did get very tiring. That's a long time to sit and talk. So after a couple of years, we kind of looked at that and decided that we needed to start focusing the case presentations down to make the clinic just a little bit shorter. During our clinic, Dr. Marcos Burgos does participate, and he is our TB medical director. So he provides direct orders to the nurses when we're doing the clinic. So they present their cases, their patients, and then anything that may need to be done, labs or anything, he can give the nurses the orders at that time. So we don't see the patients in the clinic, but the nurses do get the orders for helping the patients out. And you know, it's a great interactive opportunity. I know one of the things that the nurses say is they really like having that time where they can ask Marcos direct questions about the medical care, get to hear his concepts, the background of why he arrives at the decisions that he does. So that's been one of the high points that the nurses have pointed out almost in every monthly evaluation. So what have we done so far in New Mexico with our TB Echo Clinic? We've had 27 clinics. We've presented 97 unique patients, and we've had 142 different people attend over the course of that time. And we have given out almost 1,000 continuing education units to people that have participated. So that is like a lot of continuing education that we have been able to give out over the last 2.5 years. One thing that I guess, you know, I'm a nurse, so I kind of harp on public health nursing, and that we really need to look at nursing. We need to look at ways to retain our nurses that we have now, and by giving them the educational skills and the confidence, it helps to keep the nurses in public health. And then we also need to recruit new nurses, because all of us are getting older and hope to retire one day, so we need to have some young folks to take over for us. So this is a good way that we can mentor other people coming up in the field. So we do monthly didactics. They're only about 10 to 15 minutes, so they're very short, which I think everybody does really appreciate. Our attention spans aren't very long, so we can keep it nice and short for the best learning. I try to schedule that. We have to schedule those like a year in advance as schedule, but we only kind of pick the speakers out about 3 months in advance. And we do videotape, Project Echo videotapes all of our didactics, so they are available if anybody would ever like to borrow any of them. We do have some renowned speakers on our didactics up there, if you'll notice. Jane Carter did one on Pott's disease for us about 1.5 years or so ago. Dr. Brostrom from Hawaii did one, Barbara Seaworth. So any of those are available if anybody would like to borrow those at any time. We're more than willing to share. And of course, we need to do evaluation. You know, whenever you do a project, you want to make sure that it's effective. So there are monthly evaluations that we do ask everybody to complete at the end of the clinic. We did a self-efficacy survey of the nurses, which I'll show on the next slide. And then just recently, there was a focus group to get some information from the nurses and all the participants to find out what they liked, what they didn't like, so that we can make changes and improvements to utilize everybody's time in the best way. And one of the things we did do was shorten up the clinics, because, like I said, the 3 hours is a little bit long. So that was one thing that we have already tried to implement. So, and I can't read this, so I don't expect that you can read all that small print. But the kind of orangish slide is when we started in April of 2015, and then that kind of beigey slide is the self-efficacy. And I just wanted to point out that the nurses felt like, over the course of that time that they had become more competent and had more knowledge in their skills. We did about 10 or 15 different variables that I can always share if anybody's interested in actually having a readable slide of that. And in the monthly evaluations, just some of the comments, a lot of the people really like the video conferencing, so you can look at the people that you're talking to, and I know I really like that part too. We had always held monthly conference calls, but they were over the phone, and so switching to the video conferencing platform, I think, really allowed a better interaction between people. We do have some shy people that still don't like to be on camera, and we look at like their light fixture the whole time, but they do participate, so hopefully we can get them over their shyness. They like talking to the other nurses because most of the time the nurses are the only one in their health department, so they don't have anybody else to just talk to and run different scenarios by, so this is an opportunity for them to do that. Some of the cons, like I said, was the clinic is very long, and we're all working on shortening that up. Some unexpected bonuses. We've had some participation of our bordering states, both in the United States, and then Mexico has participated in our New Mexico echo clinics. We never really had a lot of interaction with our laboratory, unfortunately, but since the echo clinic started, they do participate monthly, and they actually come to our little hub where we all meet together, so it has dramatically improved our relations with the state TB lab. And we do have a pharmacist that comes, and she is just invaluable because there are so many drug-drug interactions, and it's really hard for anybody to be aware of all of those. So she's at each of the monthly meetings and helps us out tremendously. And one second clinic that we started in January 2016 was Navajo Nation, and that's our largest Native American tribe in the United States, actually, and it's set basically in New Mexico and Arizona is where it's spread over. It kind of has a little bit different format. There, the doctors do present the cases, and then the TB techs there are the ones that do like the community outreach and the DOT for the patients, and so they're also on the call and provide their perspective. This one is a closed clinic. Most of our clinics are open if anybody would like to participate just for general learning knowledge, but Navajo Nation really felt strongly that they wanted to keep the clinic closed to only those individuals that are participating directly in the patient care. So even though everything, confidential information is not shared, they still wanted to keep it closed. And that's one of the things that's very nice about ECHO, is I think you can adapt it to different formats and for different people that have different needs and desires. And look at that, I am done and got 2 minutes to spare. Thank you.
Thank you, Diana. So I'm hoping that even with the first few speakers, you folks in the audience are seeing the diversity and the applicability in this. So even, I know it's almost laughable, 39 active cases is like the first half hour of your morning for some of you. But think about it, high incidence, low incidence, that's a lot like your remote areas. People who need the equitable access to experts in a low-cost way. So I'm hoping you're seeing yourself in some of these examples, because there's a lot of really fabulous examples. And our next speaker brings yet another variation on the theme. Kathy Mosier, the former TB controller of San Diego, now with DGMQ, the Department of Global Migration and Quarantine. And we're really happy to hear her at CDC. And we're very happy to hear her give us information about the Binational Project. Thank you, Cap.
Thank you. And I thank the organizers for allowing me to have some time to talk about what I think still is the first and only binational ECHO project. Is that? I have no conflicts of interest. So what I'm going to do is talk a little bit about why this project was initiated, some of the unique elements of the project, give one patient example of a case we have discussed, and go through some of our outcomes. So this project was initiated in part because of the need. And you can see the states in the U.S. that have those percentages on them are the 4 states that border Mexico. And some of them have higher incidence than overall in the U.S., some have lower incidence. But one thing that binds them all together is that they have a very high percentage of their diagnosed cases each year, from like 25 to 40%, that were people originally born in Mexico. So clearly it behooves the people in those states to work closely with their partners. But even more than that, and any of you who live in a border region, these are all the sister city pairs that are along the US-Mexico border. And if you live along the border, you will know that people often live on one side, go for health care on the other side, they go to school on one side, they work on the other side, they go for second opinions on the other side. So you really need to understand what goes on in your partner country. And you may think, living in such tight sister city pairs, that you know each other. Well, some people know how the TB program works on the other side. Some people think they know how the TB program works on the other side. And some people are just too busy to really explore it, but wonder about it. So, of course, there are many things different between our 2 countries, Mexico and the US, and not only and not the least our language, but we do have very different healthcare structures. They have national health insurance, something we're striving for in the US, but we also differ, maybe not in the medications we use for TB, but in the formulations, the accessibility, the use of diagnostics, contact investigation, and all that is very important if you're co-managing or trying to manage patients across the border. So many of us, I was kind of a late adopter actually, so I'm lucky they let me talk about this, but many people were thinking ahead of their time about ECHO and how we could apply the model that had started to pop up in some of the places you just heard about in the US, how we could apply that to the US-Mexico border. And so there was finally a group of the willing who came together and said, let's think about how we can apply this. So it was the ECHO Institute, our friends from New Mexico, the folks from the state of New Mexico Office of Border Health, and we got a little funding from an entity, a government entity called the US-Mexico Border Health Association, to help us launch ECHO, and certainly from the Ministry of Health and from the CDC. And so we came up with the objectives, very simple objectives, really to increase the bilateral understanding, increase discussion about cases binationally on behalf of those patients, and really to see over time if we're learning with each other how to do management of these patients in a better way. I sometimes say that we started ECHO we launched it in July of 2017. April of 2017 was our first real ECHO session, our hard launch, but we started about a year before to really think, what do we have to do to do a binational type ECHO? And one of the things that we had to do, certainly we had to change the forms, and everyone uses a version of the form so you can do these case discussions. Well, we had to make it in English and Spanish. We also had to, because it started as a US centric form, we had to say, do all of these fields that we have there even make sense in the Mexican context? So we had to make some accommodations or changes there. We had to think about connectivity. Is it connectivity in the Mexican side the same as on the US side? I just threw politics in there, but maybe it's even, the word maybe is etiquette. You know, how do you invite people? Mexico is more centralized, the US is more decentralized. How do we choose the cases that are going to be discussed? So those kinds of things. And then one of our really unique things, we tried to figure out how you have simultaneous translation and interpretation. Because without that, if you've ever been on a binational call or international call, somehow the languages kind of veer into the most assertive people on the phone, so you can end up speaking only in English or only in Spanish, and people feel left out, so we wanted to figure out how do we overcome that. We also, I mean, it was very important, and I really have to thank New Mexico for really, and the Echo Institute for really having really good feedback after every Echo session, just so we know what everyone is thinking, and so we little by little can get it right. But this is a picture of the simultaneous translation and interpretation. We're still working on perfecting it, but think of yourself, let's say you're speaking in English, but the speaker right now, you're an English speaker, but the speaker right now is speaking in Spanish. Well, it's been figured out how you can pick up the phone and you will hear an English translation if you want to do it in an audio format, or you can actually look on the screen and someone's typing, so you have simultaneous translation in a visual format. Sometimes you're trying to do both, and you don't want to know what language anyone is speaking. But we're slowly perfecting it so that people really feel included in this format. And these are just some of the topics that we've talked about. We tried to do maybe the top 10 topics that people said were curious about the other side. Again, Mexico is fairly centralized in the way they procure their treatment for multi-drug resistant TB, and so that was a topic. The US was curious about that. The US has people, some people in immigration custody who will later be deported. And so Mexico was very interested about that because we're often, unfortunately, deporting people back to Mexico with TB. And so they wanted to know what that was all about and how that looked. So we had a very nice discussion about that. So since our start, in April, you can see that our number of participants has really increased dramatically, which we're very excited about. And so, oh, this is the patient that just so you can get a flavor of the kind of patient. This was a 28-year-old individual who was being treated in the US in immigration detention. He had, fortunately or unfortunately, come into immigration detention about 3 months previous. And the fortunate piece of that is by the time he came back the second time, the cultures came back, so we knew he had drug-resistant TB. He was started on treatment, but everyone knew that he was going to be deported again. And he was, at this point, rejecting his injectable medication. So some of the discussion points around this individual was, what is the best regimen in the US that we have to offer if you're not going to be on an injectable? What would that look like when you go back to Mexico? What is the regimen going to look like in Mexico, so we can kind of harmonize the regimen we start this person on, if that's possible? How this person didn't necessarily live in the city that he was going to be deported to. So how can the US help get the person to the right state anyway in Mexico? How would Mexico get him to his city, which will be important for his adherence? And then for all of us, how are we starting to talk to this individual about the need for adherence to his long MDR regimen, and maybe it would be best for him and his family to stay in his town until at least he was completed with his treatment. So those are the kind of things that we really need to talk about. And so our first next steps, because I'm sure there are a lot of next steps, is we still talk about improving the technology and the connectivity and the translation. A lot of people want to hear when we talk about a patient, like what happens in the follow-up. Did we figure it out? Did we do it right? But we always have didactic. So between the didactic and the new case presentation, sometimes there's not enough time to talk about the follow-up. So we're actually making the sessions a little bit longer. And then to really determine the trajectory for the future. Who are the core participants? Sometimes it's great to have a lot of participants, but you may grow so fast that not everyone is engaged in the same way. So it just been my time, and thank you very much.
Thank you. Thank you, Kathy. That was great. So it's my pleasure to introduce the next guest, next presenter, which is Georgi Kuchadzidze. And Georgi is going to repronounce his last name for all of us so that we can hear it correctly. Georgi is the National TB Program Manager for the country of Georgia. Thanks, Georgi.
Good afternoon, everyone. I'm Georgi Kuchadzidze. I'm from country of Georgia and presenting the National CDC. And I'm going to talk about the experience of developing an MDR-TB ECHO program in the country of Georgia. So I have no conflicts of interest related to this presentation. Georgia is the small country in the Eastern Europe which has 3.7 million population. We have 10 regions, 10 regions where we have the TB regional centers, and we have 69 district healthcare facilities who provide the TB treatment to TB patients. Georgia has high rates of MDR and XDR TB. 12% of new cases and 39% of previously treated cases have MDR TB, and this makes 400 cases notified per year. And unfortunately, we have the high rates of M and XDR treatment loss to follow-up, which was 34% for the latest cohort, and quite low treatment success rate in this group. Cure plus completed treatment, the combination of WHO criteria for the treatment success rate was 50% in 2012. So why we decided to start and launch the TB ECHO project in our country? First of all, as it was already stated, we have high rates of MDR and XDR TB, and all MDR and XDR TB cases are discussed at the Central Consilium in the capital Tbilisi prior to enrollment in the TB treatment, and this is especially true for those patients who are XDR and who are complicated cases. The program does the follow-up monitoring visits throughout the country, and the Consilium works on spot. So all this contributes to the delayed time. So we thought that the TB ECHO project could contribute to reduce the time and save the time and resources for the TB doctors, as well as reduce the time from diagnosis to enrollment to treatment for the patients. And also we had a successful implementation, we had the case of successful implementation of HCV ECHO project in the country. So I will talk briefly about the project development timeline. I think it could be interesting for those who plan to introduce the TB ECHO project in their respective country. We attended the immersion training, which was attended by the staff from National CDC and the National Center for TB and Lung Diseases at the University of New Mexico back in December 2016. After that, development of curriculum and case presentation forms took a while, several months. Then we did the procurement of all necessary equipment through the Global Fund TB program, which is operational in the country. And then the next step was the installation of the equipment for the Zoom video conference software, and it was done in person, in line with in-person training on the spot. And at the end, we had the launch actually last week in October. And as of the current TB ECHO structure in the country, we have National Center for TB and Lung Diseases, who is the ECHO hub, and we have regional TB centers, 9 centers as the ECHO spokes, and clinics are planned every 2 last Thursdays of each month. But in future, we plan to move, to select the spokes from the district level centers as well, especially in those centers who have more TB patients, MDR and XDR TB patients compared to other centers. And also we have we are discussing with our partners the possible involvement of international assistance in the project. As I said, we had lunch last week in the country on October 5th, 2017. And it was some kind of testing and piloting session. And 4 regions participated. 5 cases, MDR and XDR cases, were discussed. And we identified some technical issues as well that we are going to improve for the next session. But in general, all doctors, especially from the regions, they were very excited and enjoyed the session and very motivated and looking forward to the next sessions. This was very short from my side. Thank you very much.
Short and sweet is always appreciated. But we are dotting the below that you're seeing again how this can be applied in these situations. And I hope, again, I'll just say, I hope you can see yourself in how this methodology may be helpful. And so the last person joining us today to round out the session, and then we will open up for discussion. So really, you can ask about the practical aspects for your own groups. I have the pleasure of introducing Diana Warner, who's here from Guatemala at the CDC. She's the TB/HIV lead in the Central American region. So thank you, Diana. Talk about use of the TB/HIV study.
Hello, good afternoon. I'm glad to listen that other colleagues have very good eco projects. We haven't started yet, we're developing it, but it's good to know. Can I have the, thank you. For you to know, our Central America region, it's bordered with Mexico and Colombia. So it's a bridge between North America and South America. And it has 7 countries, but only 5 of them are supported by our CDC project, which is Guatemala, El Salvador, Honduras, Nicaragua, and Panama. And actually, we have representatives from all TV programs from Guatemala, Nicaragua, and Honduras here today. So, welcome. In our region, we have the same TB risk factors as we have in other countries. The poverty affects about 40% of the population. And the northern triangle of the countries of Central America, which is Guatemala, El Salvador, and Honduras, have the highest percentage of illiteracy. And the migration to Mexico and the US is a huge problem, given challenges controlling the TB across the borders. 8% of the 43 million US immigrants come from Central America, and 85% actually are from this northern triangle. So it's very important. So in our region, we have a total of 46 million people in the 7 countries and 13,632 notified TB cases. And the incidence rate is highest in Panama and Nicaragua, as you can see. And the density of the cases is highest in El Salvador, which is the smallest country in the region. For HIV, we have 163,000 people living with HIV in Central America, and the Northern Triangle has the majority of the cases. About 10% of the people living with HIV have a co-infection with TB. And most of the cases are located in the big cities and municipalities that are in the Pacific coast and next to the border with Mexico. In 2015, we had about 450 TB MDR cases, which is 4 times as much as the United States. And the incidence rates range from 1.3 to 2.8%, and they're highest in Panama and Belize. Only in Guatemala, we've seen an increase of TB MDR cases. There were 214 TB MDR cases between 2011 and 2016, and they are located, living in 63 municipalities, also close to the Pacific coast and next to the border of Mexico. So why TB echo in Central America? We have many, many challenges, but one of the most important is that we have a very low detection rate. It's about 30%. And also we've seen increased number in the cases lost to follow-up in the TB MDR cases, and there's increased number of cases among healthcare workers. Also, there's limited training opportunities. They have some international opportunity trainings, but there's very limited access for experts in the region. So we're going to begin Echo Pilot first in Guatemala. The hub will be located in Guatemala City, and the spokes will be in our PEPFAR-supported sites with highest TB HIV burden, which are Guatemala City, Escuintla, Malacatán, Coatepeque, and Quetzaltenango. Also, the TB national hospitals are located in Guatemala City and Quetzaltenango, and they will be included in this ECHO. After this, we're going to add the other locations, other countries, Panama, Honduras, Nicaragua, and El Salvador, and different spokes in each one. We'll try to include a different clinic also for our Garifuna population, which is an indigenous population with very different cultural interests. So we have different ECHO modules planned. We already have the National TB Program Director already has a certificate course that we're going to place for case management. And we're going to also create an adverse event reporting system. And we're also going to include later other clinics in fungal infections and in HIV because the comorbidities are high in this region. There's like 22% of comorbidity of TB and fungal infections, and 10%, like I mentioned, with HIV. We're going to have this clinic, of course, in Spanish, and we have an implementing partner, URC, who will be providing the staff. They're going to go to the training next week. We're going to have the clinic outline and tools developed, and some of them are going to be translated, which have been used in other projects. And of course, it's going to be coordinated with the local ministries of health. We're planning to launch in January 2018 in Guatemala City. So what challenges we might have would be that some places in the rural areas have very limited internet access. Also, the computer skills of some of the healthcare workers are very limited. And the availability of Spanish-speaking TB experts. We have some in the region, but they're probably very busy with busy agendas, so we have to be able to either translate to international experts or get the ones that are local. Also, we have limited funding for expansion, so we have to work with collaborating with other agencies. So these are some of the collaborating agencies. We've been participating in the TB Meta ECHO, which has been very helpful. Also with the U.S.-Mexico binational ECHO. And this is going to be important with the countries from the North Triangle. Guatemala has already participated in these calls, and they're going to be ready to soon present some of the cases also in this ECHO. And then other collaborations would be with USAID, because they also are going to have a TB program next year, and PAHO and the Union, of course, which are the ones that give all the international trainings to our region. Oh, wait. And then we have potential expansion of our ECHO, of course, to other countries in the Central America region, even if we don't cover it with our funding, which are Belize and Costa Rica. Also, we have some collaborations with the Caribbean countries like Dominican Republic, and it could be also included. And we have potential development also of training other people, Spanish-speaking countries in Guatemala. And that's it. Thank you.
I think I'd like to invite our speakers to come up, and we're going to move into a question and answer session. And so again, I have to tell you, so I'm from a training and education center. One of the regional centers of excellence supported by CDC in the US. So basically I'm a teacher, which makes me practical at it. And I'm also a clinician, and I think many of you in this room are the same. You're here because you're interested in capacity building that's practical. Right? And so I think what you've heard is a variety of the classic example of what do you do? How many of us are getting more money every day to support our programs? Not, right? What can you do to still reach those new and struggling providers, the new and struggling programs, the new treatment initiations like our DRTB? What can you do with what you have on hand now? And I would venture to say, none of us here are swimming in cash. Most of us have a cell phone or internet connectivity at work. So I'm wanting you to see the faces of the people who are taking this methodology, they're taking it to scale, and they're taking it to meet the needs of all the different issues that have come up, be it increasing case finding, increasing quality of care for difficult cases, reaching across borders, finding cases that have gone to Somalia, right, Kenya, from training up your next nursing workforce. So I'm hoping that some of you have questions for these guys, because this is a panel of really, practical, we've been there, done that, we're doing it people. And so I want you to be able to take this opportunity to ask some questions to figure out how can you apply this in your setting, or how can you stretch what you're already doing to make it work even better. So anybody? Yes, I'm going to have someone run a microphone down.
Is that live?
So thank you very much for very interactive and useful presentations. We learned a lot from you. I'm from Vietnam. We also apply ECHO for some important capacity building, particularly for India, for charity, and for some other need of technical capacity building for health staff, particularly for local areas. And one of from your presentation, I would like to ask one question. We could see very important effectiveness of ECHO projects, but I see that many of your projects supported by Global Fund or other sort of funding. So how we sustain the project after funding source may be not available? How to maintain the network? How to maintain the equipment? And how to provide further support for newcomer from TB network in different area, particularly from remote and difficult area. Thank you.
Thank you for that question. I'm thinking, I was hearing, really it's about maintenance of a program. How do you get it up and going and sustain it? So sustainability, especially in difficult settings or difficult means, I think we have Who would like to talk about it? Who's got the longest program going here? Kameni, Diana, Kameni, both of you. So really, how did you convince them? How are you maintaining it? And any helpful hints? And I'm going to start on this end, if that's all right, Diana.
For me, starting was a bit of a challenge because we didn't have a lot of equipment and money. But all we did was give them a logging detail, and we trained them using Echo. And from there, we just set up a date and one meeting ID and a weekly reminder. What we discovered interfered was mainly if you don't do it consistently, people start to lose interest. If one time they call in and there's no one, they join another time, they call in, there's no one, interest starts to disappear. 2, if you keep on discussing the same story every other week, people get bored. So if you change, people find it exciting to join another time and another time. So that also kept the tempo. Of course, sometimes we lose people along the way. So in meetings, we remind them, use other colleagues to remind them. And then also in setting the time, you request them to give you what is the best time for them to call in. So based on the average, you agree, okay, this is what works for most of the people. So involvement also helped for us.
Well, I think I can just add to what she has said. We had about a year's experience. There are 2 components to your question. One is maintaining the so-called the hardware and the equipments and all that. That is one part of it. And the other part is sustaining the clinic itself. That is the second part. Now, as far as the first part is concerned, it is important to have a separate, dedicated team to look after the equipment other than the technical team. You see, the technical people should not be bothered about the nitty-gritty of internet availability, the television screens working properly, and things like that. There has to be a separate team which will be addressing that, and they will be doing that constantly over the period. So that's one part, that have a separate dedicated team for the equipments. Now, in terms of sustainability and long-term scope of this particular methodology, I would agree with her that the timing is very important. You see, we have to understand that certain, say the clinicians may have a different time frame of availability, and they may say you host the clinic somewhere in the afternoons. The health worker may say that, well, I am available only during the time when I spend on my lunch. So you host it around, say, 1 o'clock in the afternoon. So like that. So, we'll have to adjust these clinics. And then the topics which are to be discussed should be relevant to the audience. You can't discuss the same topic for the clinician and the same topic for the dot provider. The issues involved will be very different. So these are the things, and every time you have to look at the audience and try to address the issues of the audience. These are some of the ways in which one can hope to sustain this. But definitely one will have to also think in terms of scalability. Currently, like in India, I have showed that we moved from 1 hub to 4 hubs, and now we are moving to other states in the country, other provinces in the country. But it has to really be scaled up to you see a larger audience. So that's another challenge which I would say needs to be looked into.
The only thing I could add to that is we're going through that exact exercise maybe right now. And so I think it's been very important for us to start to think about, with our binational program, whose program is it actually? Is the hub in the US? Is the hub in Mexico? Is it a shared hub? Are the expenses eventually going to be shared expenses, and really understanding what those expenses are. We have the added expense of the translation, but really understanding what are the costs, and then the whole other piece about, your audience and what their expectations are. So I would say you really have to think about all those things up front.
Any other questions? Any other questions? Yes, please. He's got a mic right there.
Thank you for these interesting presentations. Really, I think this is the way forward in terms of capacity building. My only question is, does the internet work? Do we always have connection? Because I have some experience with Skype calls, just connecting to colleagues all over the world. That's already quite a challenge often. So what are your experience with this connection?
Kameni, are you willing? I mean, I think one might think that Kenya might have challenges with internet, so I'm curious what your experience has been.
I think the most important, from experience, the most important internet connection must be the hub. If your hub is connecting, then at least you're assured the people who are listening to you are not falling off. But the challenge we have is when for the longest time I was the only person in the hub. So I used to be the host and the internet person and handling the chat and everything. So when I moved town, then would keep on falling off. And then you keep getting disconnected and it moves to another person who suddenly becomes the host and everything goes wrong. But as long as the host is connected, I've realized most of the time you'll find that the session will go on well because majority of the people anyway will be connected. Does that mean most of the places we have internet? No. There are parts of Kenya where they are still using 2G, so that such places setting up has been a challenge. But we are using boosters, so we are using boosters that are being used in the hospitals to try and encourage people to still connect. But yes, internet is a big challenge where it's not there.
Yes. So just so you know, I don't know if people, sometimes there's a confusion about when you hear these people mention Zoom. Zoom is a technology like Skype. Can get a free version, you can get a paid version that gives more bells and whistles. It appears to utilize less bandwidth. So sometimes you have a little more stable connection. It's not without its hiccups, but that's helpful to have something that's a little bit more stable. And then with any platform you use, you usually can also do audio only and reduce the bandwidth requirements, or sometimes just do it on cellular. So I think that some of you may have more advice, but what I've found, so I've helped similar systems grow. My CP colleagues from Uganda, the Challenge TB programs in Tanzania and Indonesia are starting to spread this out. And there are people who are joining on their cell phones in their car while they're commuting home, hopefully not driving. And that, so it's, if it's not there, it is coming, because the world's internet base is growing, number one. Number two, there are short-term solutions where people can still join. And I think, again, looking for programs that have maybe a little more stable bandwidth issues is helpful. And we have no stock in any of these programs, so, but we're finding what's most useful. Anyone else with advice?
I just want to add, since we've been doing the preparations before the launching, and I think it's good to be prepared to get all the exact requirements for the internet and everything ready, so that when you're doing the clinic, it's going to be working. We've been doing testing, and this platform Zoom is way much better than others that we've tried before with the Skype or WebEx. So we've tried it and it's been better, but you have to have the right equipment, and yes, we have to support the sites for them to have the right connectivity before we begin.
Yeah.
And I just might add, with a program in Namibia, one of the reasons it's important to work with partners and tell all the possible partners you might work with about what you're doing. the National Laboratory Program in Namibia was upgrading its internet connectivity to the 40 largest hospital labs across the country. They were able to piggyback on that internet upgrade and take advantage of it. And in a collaboration between the National HIV Program and the National Lab Program, they ran extra cable to the HIV clinics, which cost very little to do that when they were making this big investment in this backbone for the labs. So, they have better internet than we have in New Mexico, frankly, now. But the other approach is to work with sites that have access to decent internet, and you start there. And as Lisa said, every few months, the internet's getting better. The cell phone networks are getting stronger. I mean, the cell phone network here is amazingly good and, way excellent. So I think you can start it with a small footprint, and that footprint can then grow.
Other questions?
I just wanted to add one small thing. As I mentioned, we had the first session and we identified some technical issues, and one of the issues was related to the internet connection in one of the spokes on one of the sites. And actually what we decided and discussed is to bring some alternatives for the centers, like with having the regular cable internet and plus probably having the mobile network in the center. So in case there is a problem with the cable internet, to switch to the mobile one. But it depends again on the country and on the resources and so on and so forth.
Great. Please.
And ma'am, just to add to, the issue on internet, sometimes problems of electrical connection is also there, because internets may be boosted through a mechanism of boosters, and if the electrical supply gets disrupted, then obviously the quality of the transmission will get affected. So I mean, as I said, that you need to look into all these things before you plan out a clinic. That the timing should be such which should be suitable and there should be good electrical supply, there should be good internet connection. And we found the Zoom platform to be very comfortable, that's a nice one.
Download the free program and play with it. Call your family and friends and see if you like it. Please. Last question. Thank you.
Thank you so much. Great session. Just one quick one. What startup costs are we looking at? Just to set up this, and probably maintenance costs to maintain the system running monthly. How much does it cost?
So probably I will answer that question, but again, it depends on the context and it depends on the country. But in our case, we had minimal expenses, I guess, because we had already in place the clinical consilium, which was doing the same job but on spot at the central level, and then traveling to the sites themselves, the clinical experts, and doing on-site training for the doctors. So actually in our case, the ECHO project decreased the costs of this expertise, and the only expenses we had was related to the equipment for the centers, for 9 centers, and the actual training of the national employees of National CDC and the National TB Center who attended the training at New Mexico University. And rough, approximate budget for, in our case, was just $20,000 US, which was funded through the Global Fund program. That's our experience.
I think the easy response is it depends. And really the main costs are human resource costs. So human resource costs are variable. They're one cost in Kenya, they're a different cost in the United States or wherever you might be. But once you've gotten the IT infrastructure laid down, then really most of the costs are human resources. It's, do you need to pay your experts, or are they already on salary with the Ministry of Health, or do they have a salary with the academic medical center, or do you need to buy 10 or 20% of their time to put into this? You need a coordinator, you need an IT person. You may not need 100% of that person. In New Mexico, our IT person will support 5 different programs. Our coordinator might support 5 different programs. So, there's economy of scale when, as Kameni said, right now in Kenya, there are about 5 to 7 different ECHO programs on HIV, TB, laboratory, an autism program, a palliative care program. If you're able to share services and costs, then that can make things much more economical. But I think with that, I know we're over our time, and I want to thank our panelists in particular for fabulous presentations, and thank you all for joining us. I also want to give a shout out to Amy Armistead up front here, who supports all our TB ECHO programs around the world, giving them technical assistance. And I want to thank Lisa, and I'll let Lisa say something before we sign off.
No, just thank you for sticking it out through the afternoon, and I think people are up here to help advise if you have more questions. So thank you for joining us. Enjoy the rest of the conference.